Thank you very much, Kostas, for the introduction and very, very good presentation, Dr. Lignos. This topic is more like the elephant in the room. Nobody wants to talk about economics and the economic impact in the healthcare system. So I believe being the only non-medical doctor speaker here, it's good to pick this topic. So first and foremost, what is the current reality in healthcare systems? And that is something pretty common across the globe, across Europe as well. And there are 5 key elements here. First of all, healthcare systems get a lot of pressure that comes from different areas. Number 1, financial constraints. Number 2, inequality in healthcare. Even within the same countries, we see many times that there is inequality in access to healthcare. There are efficiency drawbacks, and we will talk about that a little bit. We already talked from the clinical side about the efficiency drawbacks. Staff shortage, which is a global phenomena, and significant backlogs. And of course, COVID era didn't help to that. It actually made the entire situation even worse. We can see here a little bit of the spendings across the different countries in healthcare. And you also can see here, talking about the staff shortage, the doctors per 1,000 population and how it is being served. So in different countries, you can see some little variation, but not much. In Greece, there is this paradox of having significantly good amount of medical doctors, but lacking all the supporting staff, nursing, and all the rest. So this is something to highlight here. So what is the economic impact of cardiovascular disease? And this is also something that sometimes it's very difficult to recognize it until you put it in the visuals. So the cost of cardiovascular disease in Europe is 282 billion euros. Only in Germany, the ischemic heart disease and the myocardial infarct cost around 10.8 billion, and it increases almost consistently by 15% year over year since 2015. That is a number that I couldn't believe until I got very deep into the analysis. And according to the ESC report that published last year, depends on the healthcare system, it is between 6 to 19% of the healthcare budget that assigned for cardiovascular disease. On the right-hand side, only for illustrative purposes, using the ESC Atlas Interventional Cardiology datasets, you can see the estimated PCIs per year. The total cost here is an average cost, of course, and of course, how that looks like. But once we start putting it on the larger scale, only then we can understand the impact of cardiovascular disease from the economical standpoint into the healthcare system. And what is the role of imaging? So the role of imaging is actually to democratize cardiovascular disease management. So there are 4 key parameters here. Number 1 being the triage. So we want to avoid, from all the different aspects, including the financial aspects, we want to avoid unnecessary invasive procedures. So CMR guided approach reduces by 30% the ICA, the interventional coronary angiography procedures, and it's not with non-inferior outcomes as the MR Inform suggests. We have the enable risk stratified prioritization. So by having imaging as the gatekeeper, we can prioritize the patients with obstructive cases. So in this situation, we can have kind of a 2-ways approach into the system. We can downstream the resource savings and having shorter stays in hospital settings. So apparently with a 20 to 30 minute CMR or CT protocols that doesn't require an admission, we can quite significantly shorten the expenses from admitting patients into the healthcare system. And another area that hasn't been highlighted a lot is that we can shift part of the CVD management into the outpatient, which is something that is critical, especially in very in very large healthcare systems. I can talk about NHS England, where I have very good visibility there. That is a key area for them in order to reduce the backlog, but also to reduce the patient traffic, as it's called, into the healthcare system. And here on the right, you can see the different features that stress MR and stress CT can offer. Detect ischemia non-invasively for both, in stress CT primarily on epicardial. Quantitative perfusion is objective. We discussed a little bit earlier about the numerical biomarkers and the value of quantitative perfusion being numerical. Enables comprehensive risk stratification, non-ionizing radiation for the CMR, minimal dose or a dose that is reduced over the time in CT, and it can be all done in an outpatient clinic in 20 to 40 minutes protocols. What is the current diagnostic split in different countries, again in Europe, for the ischemic heart disease? So we can see that UK has adopted the NICE guidelines, which is CT first approach. You can see that the CMR or CT perfusion there has a very significant amount of being the gatekeeper to that. And the ICA being the first test is pretty reduced. And that is very important to show you what is the next slide, showing the economical impact on this. And then there are other regions with different approaches. In Germany, we need to justify and to highlight here, and Matthias, probably you can comment to that, there is a high capacity of ICA, and that is something that it's a privilege to have high capacity. So still, that's why you can see that the ICA is at a high rate. In Greece, this is more of an estimate from different registries, which I believe probably Dr. Ninos, Dr. Kalfatidis, Dr. Michailidis, you can comment if that is close to what you would expect to see. But I believe in this meeting, having many participants from the Balkan countries, you might see many commonalities to the situation that exists today in Greece. And what is the economic impact of that? So the Discovery INOCA registry from last year, that it was a large registry, suggested that 30 to 50% of the elective ICAs is for non-obstructive cases. So apparently this means that up to a half of the patients who undergo an interventional approach, that could have been avoided if we had imaging approach as first line of exam. And then there were in the registry some estimated costs for the total system cost. And here, a very simplified model, and I need to highlight that, to disclose that Greece is estimated again from the different registries, because a lot of that take place in private sector. If 100% would undergo an ICA, and 35% from these 30 to 50% were non-obstructive cases, and let's suggest that stress imaging would avoid 70% of them, because still the 30% would be cases on the borderline that we would suggest for an ICA. We would be saving 245 cases per 1,000 ICAs. And here you can see an estimate of the impact just on 1,000 cases. In UK, the reason why you would see a reduced number is, first of all, because there is the NHS tariff on the ICA, which is significantly reduced. And secondly, is because we don't have so many cases as we suggested. But these are very elaborating numbers on proposing the economical impact of imaging. And then we talk about the challenges in cardiovascular imaging. So we all experience some challenges here. One is that we talk about time in a scanner that is not dedicatedly allocated for cardiovascular purposes, for cardiovascular cases. So first of all, we have the clinical challenges. We all appreciate that the cardiac cases are probably the most challenging cases, with complex cases, with workflow inefficiencies, and with time pressures. We have the demographic pressure. We live in Europe in an aging population, and that increased a lot the requests for cardiovascular treatment and diagnosis and treatment, and we have long patient waiting times. There is the staffing challenges that I believe we experience all across the globe, but also significant in Europe. We are in need of specialized expertise, both on the medical and the non-medical, the supporting staff. And we have increased strain on existing staff already. And then is the financial constraints, where there is limited infrastructure for funding, there is restricted access to capital, and also high equipment costs and very limited reimbursement rates. I showed in the presentation I did earlier today that only now the stress perfusion is in the CPT code in the US. And here we can see a little bit the capacity and efficiency trade-off. So indeed, cardiac MR and cardiac CT perfusion guided cases will reduce the ICA volumes, but at the same time, it shifts the diagnostic burden to the images units, which, as of the previous slide, they are already under pressure. The AI adoption and the next generation of scanners, so the AI adoption on the post-processing side, alongside the next-gen scanners, primarily photon counting CT, which is a new modality, as we call it, with unlimited capabilities, they will further optimize precision diagnostic, will get us closer to what we discussed earlier today into the numerical assessment, into objective assessment. But the reimbursement pathways still require reevaluation. The CMR perfusion offers highest diagnostic accuracy today, but the reality is that CT perfusion is more scalable due to the accessibility. It's wider and broader accessible, plus the throughput that it can generate due to the shorter protocols. So all in all, we need to be aware of the capacity and efficiency trade-off, and the net effect is subject to investment in imaging capacity, adoption of AI in clinical practice, and workforce availability. And closing, to see the big picture. So what image-guided ischemic heart disease management can deliver. Number one, positive economic impact to the healthcare systems. That is something that registries have shown it already, and it's something that is that it's very high in the agendas of reimbursement and healthcare spendings. Socioeconomic improvements that will address the global health disparities. That goes more into the to the patient's lifetime. It goes more into the impact not only on the economy, on the economical aspects, but how that impacts the societies themselves. How can we offer better health for the patients? Improved hospital level efficiency towards a human-centric and inclusive healthcare system. So with shifting some of this traffic into the outpatients, that will help and will improve the hospital level efficiencies. And then we will only have into the interventional rooms the cases that really need to prioritize and reduce the backlog of all the other cases that are priority, but today we cannot stratify them as such. And last, transformative technologies that are fully integrated in the clinical practice that will deliver the precision diagnostics. Dr. Goyen, you spoke earlier about precision diagnostics. And I think unless we are able, all these technologies to be integrated into the infrastructure, into the workflow infrastructure, they will not be feasible to have a clinical adoption in the daily practice. So that is another parameter that many times us as manufacturers focus in all the other work other than how to deliver the transformative technologies. And that is a key point where the industry should focus quite a lot to deliver more precise diagnostics. Thank you very much for your attention.